Hi everybody, we're going to go ahead and talk about HIV. It's chapter 20 in your Williams and Hooper. You can also find some additional things in your ATI Adult Med Surg book. So we're going to go ahead and start talking about HIV and what it is, if I can get my stuff to work here. So as HIV starts, when you first come in contact with the virus, you're going to have certain symptoms that are going to occur within about the first 2 to 4 weeks of infection. So they're going to kind of be like influenza. So you're going to kind of feel, fever, night sweats, chills, headaches, muscle aches, just like you would think if you had influenza. You might even have a rash and a sore throat. That's kind of like the acute one. Usually these symptoms are temporary, and usually they're going to go away. But what's actually happening is you're having a rapid rise in your HIV viral load and a decrease in your CD4 cells. So let me explain a little bit about HIV. So HIV actually copies itself, and I will get to that here in just a minute. And so as HIV copies itself, we call that a viral load. So the more copies of the virus, the sicker that you are. And the cells that actually are involved in fighting infection in our body is called the CD4 or T lymphocytes. Or your CD4 cell counts, your T lymphocytes. Those are the specific fighter cells that are involved in fighting infection. So you can see if HIV invades and kills those CD4 cells, then they can't fight infection. So that makes them more prone to infection. So usually when that viral load goes down, after the initial infection, the viral load will go down and the symptoms go away and you feel a lot better. Now, the one thing that will happen with AIDS in all patients, they have what we call lymphadenopathy. So if you just break that word down, it just means your lymph nodes have disease in them. And that is going to persist throughout the disease process. So you will always have some of that lymphadenopathy. But back years ago when I first became a nurse, a lot of times it was kind of like COVID back then. We really didn't understand what HIV was. We didn't know how it replicated. We really didn't know how to treat it. We didn't know how it was spread. So now that we have had many, many years of, researching and understanding AIDS, we now know that it pretty much people 30 years ago, if they got it, it was kind of like, okay, you're going to die because we don't really know how to treat it. However, with all the new medications, all the new advancements, we consider HIV now as just a chronic infection. So it's something like emphysema, COPD, that's just a chronic illness that we're going to be able to treat now. So some people can have what we call a chronic asymptomatic infection. So that just means that they don't have any symptoms. And so they don't even know that they have it. They're asymptomatic, and they can be that way for years and years and years. Now, they can still pass the infection, but they just don't have any symptoms. So when someone's HIV positive, they're going to produce like anti-HIV antibodies are produced when you're positive. And that's what we're going to look for to determine if somebody has HIV. So over time, that virus will, once it lays latent or dormant, but over time that virus will start to replicate again using our own genetic machinery. So I'll explain that here in just a minute too. But the way viruses replicate, they use our DNA, they use our cells to replicate, where bacteria have their own cell wall and we can get antibiotics to penetrate that cell wall to kill it out. Viruses don't do that. They live within our cells and they use our own DNA to help us replicate. So what's going to happen is those CD4 cells are going to get destroyed. Those viral loads are going to increase, and we have a dramatic loss in that immunity. So then we become AIDS positive. So there's two different things. There's HIV and there's AIDS. You can have HIV and not have AIDS. AIDS is the acute condition. HIV is just that chronic asymptomatic, 20, 30 years of latency that as long as you're taking your medication, you're doing what you need, you don't have any active infection. But AIDS is actually defined by a CD4 T lymphocyte count less than 200. So if your CD4 T lymphocytes get less than 200, that is considered AIDS. But you have to have all these other things too. So you have to have an opportunistic infection or an opportunistic cancer. And we're going to get to those here in just a little bit too. So AIDS is characterized by that life-threatening opportunistic infection. And I'll talk about what those opportunistic infections are. This is the end stage of HIV infection. So without treatment, death is going to occur pretty quickly. All people with AIDS have HIV, but all people with HIV don't have AIDS. So kind of keep that in your mind. Someone can be AIDS positive for years and years and years, but they don't develop the AIDS, which is the acute form of it. So HIV, this is kind of how it works. So HIV, this is the pathophysiology of it. So the way it works, and I'm going to show you a picture which makes a little bit more sense. The HIV have like 1, 2, 3, 4, 5. They have 7 different steps that it takes to make the HIV happen. So what happens is in the binding stage, the HIV is going to bind the CD4 receptors of our host cell. So HIV is going to bind to that host cell. Then it's going to fuse the membranes together. Then what it's going to do is going to use something called reverse transcriptase. And that viral DNA that's inside that HIV is like viral RNA, but it's going to convert to DNA. And then integrase is when it integrates into our host, into our cells as DNA. Then once it does that, it's going to replicate. So it's going to take that host cell and it's going to make HIV proteins. So it's going to use our own bodies to make more proteins. And then it's going to kind of package that all up really nice into what we call like a viral envelope, and it's going to make new HIVs. And as those new HIVs are made, they bud and they release. So making it make a little bit more sense, this is what our normal immune system does. Remember the phagocytosis, where it's like the passive immunity that we have. So we have our little viruses here. They get into our T cell, our CD4 cells, or our T lymphocytes, and we destroy them. And these T4 cells right here come in, they eat them up. It triggers our B cells to release antibodies, and then our antibodies go out and they destroy the virus. So we ingest it. The T4 cells are going to multiply to attack the virus. Those T4 cells are going to make antibodies. Those antibodies are released into our serum, and those are going to go attack that virus. That's what should happen in our immune system. In AIDS, our phagocytes, because of the nature of the virus, the phagocytes can't do that. They can't ingest them, and they can't digest them, and they can't make them different. So that HIV is unharmed, and it throws it back out into our system, and then it kind of goes in and it takes our lymphocytes here, which is our good T cells or our CD4 cells, gets inside there and starts making itself more, and then replicates more, and we don't make antibodies. And so that infection just keeps getting more and more, and that HIV virus comes in and attacks our own lymphocytes. And each of these lymphocytes that it attacks, it does this same process here. So it buds off, it does the replication, it does the binding, it does all of that stuff. So that is really important to know, these kind of steps, because the medications that we use to treat HIV get the virus at each of those different steps. So the treatment is antiretroviral therapy. So what it does, we use fusion inhibitors, and it blocks that fusion of HIV inside that host cell. So that's one medication that we can use. Then we can use entry inhibitors, and what these do is block the certain receptor on the CD4 T cell. So it kind of blocks that HIV from getting inside there and prevents the progression of that disease. Then we have nucleoside reverse transcriptionase inhibitors. So if you go back, there's our reverse transcriptionase. And these interfere with the virus's ability to convert. Remember when it converts the RNA into DNA, not DNS, DNA, it converts it into the DNA. That prevents that from happening. Then we have also other ones that inhibit the virus replication. So it doesn't allow the virus to replicate inside those host cells. Then we have protease inhibitors. If you go back here, we got our protease that are in here. We have those protease inhibitors. It stops that enzyme needed for that virus to replicate. So it prevents that enzyme from replication. And then we have integrase inhibitors, and they stop the viral replication by stopping the HIV enzyme integrase from inserting into our host DNA cell. Then we have anti-neoplastic medications. This prevents any type of metastatic or cancerous. So it takes the interleukins in the immunostimulant, and I know a lot of this is like foreign to me. So don't get mixed up on what all of this is, but what I really want you to know is a lot of our antiretroviral medications that we use, they stop the virus at all of the different steps that the virus needs to replicate. So a patient might be on multiple medications in multiple of these different sites, if that makes sense. So they might be in different things. So the patients aren't just going to take one medication. They're going to take multiple medications to stop the virus at all of those different steps that they're using to get. So going back to how we treat it or how we manage it, what are some risk factors that your patients are going to have? Well, if they have unprotected sex, if they have multiple partners, because we don't always know. A lot of times if they're in that asymptomatic phase, they might not even know they have HIV. And you know, they don't feel sick. Occupational exposures, that would be like occupational blood and body fluids. See, people that work in, you know, healthcare. It is pretty rare that we get anything in healthcare, but it's also out there, and it's something we need to think about. Perinatal exposure, that's going to be babies, moms, going across the placenta barrier. Blood transfusions. And in our country, rarely are you going to see a patient get HIV from blood sources. So, we do, when patients have to have blood, that's one thing that is a big fear, because back in the early 80s, that is how many people got HIV that were, not doing all of these risk factors, but because they had to get blood transfusions and we really didn't know what we were looking for in blood. So in our country today, it's really not a good source of HIV that they're going to get. IV drug use, contaminated needles. That's why you'll see a lot of times the health departments passing out, sterile needles. I know there's controversy over that because they feel like if we're passing the sterile needles out, we're promoting drug abuse. And in my eyes as a healthcare professional, I would much rather see them getting sterile needles than passing diseases, hepatitis and AIDS and hepatitis C back with other people. So older people, it is something that we have to think about in our older adults. It can go undiagnosed in our older adults because it does, manifest like a lot of other types of diseases in that older population. They're more susceptible to fluid and electrolyte imbalances. They're more susceptible to malnutrition, skin alterations, and wasting syndromes. So our older people are going to be more prone to some of these things. Females are more prone. Our older females are more prone because they have dryness and thinning of that vaginal wall. So there's going to be, when the sperm is deposited there, it has HIV in it. It's going to be able to get into the system a lot quicker because of the vaginal dryness. It's, sometimes there's open tissue. There's the mucous membrane inside there is not, it's bleeding a little bit, and so it gets inside their blood system. So they're a little bit more susceptible. So how is how is it transmitted? The mode of transmission? Well, it's going to be transmitted by infected blood, semen, vaginal secretions, breast milk, and mom to baby. So it is not spread casually. So we're going to use standard precautions for all patients with HIV. You can't get it from hugging. Don't get it from saliva or sweat. So it's not in a high enough concentration to really cause any problems. However, you want to teach people that are living with HIV positive people to take certain precautions. So there is a medication that is out there that can be preventative from getting HIV. It's called pre-exposure prophylaxis. We call it pre-ep, and it is effective in preventing those patients that are at the high risk, that we know that they're high risk people. We start them on this drug is an antiretroviral drug, so it's going to stop at a lot of certain of those abilities of the HIV to replicate. So the drug is called Truvada. It's called Truvada. This drug has to be taken every day, and it has to be taken consistently in order to prevent that infection from, progressing. And it's used with other transmission precautions that we have. So how do we diagnose HIV? HIV is diagnosed, we do like a screening test. It's called the ELISA. It's an enzyme-linked immunosorbent assay. And if you have a positive one, we will do another test just to be sure that we are right. You can have a positive test and it be, you're actually negative, but the test comes back positive. So we do it again and use what we call a Western blot. So we use the ELISA, and the Western blot is what we use to diagnose HIV. There are home kits that are available that are done anonymously, but many times patients have to have counseling prior to being able to utilize those kits. There are 2 non-invasive tests that can use mucosal fluid or urine. But if a patient gets a positive test, what we want to make sure is look at is their viral load. So what we're going to look at is how many HIV viral replications do they have in their body. If someone is HIV positive, they're going to have multiple copies of that HIV virus, so they're going to have a high viral load. If they don't have any, it could be a false positive. So we're going to look at those viral loads at that point and see where that patient is. So per CDC guidelines, a lot of times we're doing a lot of routine testing now on people just to catch it, because remember, they can be positive and show no signs and symptoms. So how are we going to catch those people so they know not to go out and transmit it to other people? One, we do routine testing. So a lot of times our patients between the ages of 15 and 65 are going to get routine testing. Pregnant females, every pregnant female will get an HIV test. If they have a sexual assault, they will get an HIV test, and then they may test them again, later to make sure. And a lot of times if it's a sexual assault, they will go ahead and put them on the pre-ep just to make sure that we don't have any types of transmission. All of this counseling is confidential and it's anonymous. So these are trained people that are going to talk to them about that, explain the results, help them, inform them about, limiting their sexual partners, not sharing needles, all those risk factor reduction kind of things that we can give. And then we're going to talk to them about what kind of options do you need at this point. So we will talk to them about safer sexual practices. Abstinence is probably the best one. Monogamous sexual relationships, so just having that one person. Limit those sexual partners. Use those condoms, use dental dams, use latex gloves, anything that we can stop that progression or that exposure to that disease, that virus. So healthcare workers, how do we prevent it for ourselves? Hand hygiene is going to be our number one. Use our PPE. So remember, when we start out with our tier 1, that is our standard precautions. So standard precautions means that if you're going to come in contact with any blood or body fluids, we're going to use gloves. If you think there's going to be anything that could get on your uniform, you put a gown on. If you think that there could be splashing, if you're taking out an IV on an AIDS patient, you should always wear goggles, wear your eye protection. That way it doesn't get in your eyes if it splashes back. If you're removing a catheter, always make sure you're using that, because you don't always know when it's going to get a splash. So ways that we can prevent, needle sticks is the biggest one. We have AIDS is what really provoked us to figure out what ways we could do to prevent exposure to healthcare workers. So that's how we came about with the needleless system. That's how we came about with all needles that have safety devices on them now. Back when I was a nurse, there was no such thing as safety devices. We were told not to recap, but yet you had to walk through the hallway with an open needle. or you had your needle box right there and you went over there and stuck it in. So we have all these safety things in place now, and a lot of it came from when AIDS started to come out years ago. So patient education. What are we going to tell our patients? They need to have good body hygiene. They need to have frequent hand washing. They need to avoid any crowded areas. Avoid traveling to other countries that have poor sanitation, because remember, this infection attacks their immune system. If they're living in America, we take certain sanitation measures, but if they go to a foreign country where they might not take the sanitation measures, they're going to be exposed to more things that their body isn't going to be able to fight off. They need to avoid like raw foods and undercooked meats. There are certain infections that are passed through raw meat and Shigella and all of those types of things are passed through raw or undercooked meats, and they're going to be more prone to getting those infections. They don't need to be cleaning a litter box because toxoplasmosis is found in the cat feces. And if they clean the litter box, that's going to be an exposure that they could avoid by not cleaning the litter box. Keep their home clean. Avoid exposure to family or friends that have cold and flu symptoms. Wash their dishes in a dishwasher using the high heat. Bathe daily using that antimicrobial soap. That way they get all the bacteria off their body, and that bacteria doesn't come in and cause any types of infection. They have to adhere to their antiretroviral medication dosing schedules, because remember, they're all going back to those antiretroviral medications are working at certain points with the HIV virus, and they have to take it at certain times, and they have to take it forever. So they need to be educated on compliance. Frequent monitoring of those CD4 counts and those viral loads. So they're going to be watching that all the time. Where are their support systems? Do they have family members? Do they have a church group? Do they have a support group? What can we get to them to help them with their support groups? Report any new symptoms or anything that they might have infectious-wise to their doctor immediately so they can start getting treatment. Okay, so back to our pre-ep. If you have a post-exposure, so let's say that you have an exposure, what you're going to do is you need to seek any kind of urgent medical care at that point. So maybe you've had unprotected sex and they tell you afterwards that they have HIV. Maybe you've been sexually assaulted and you don't know who the perpetrator is. Maybe you've splashed something in your eye. Maybe you've got something in your mucous membranes. So that is an urgent medical care visit. You need to go do that. If it's an exposure in your eye or at the site, wash that site with soap and water for several minutes. Mucous membrane exposure, wash that mucous membrane for several minutes, washing that out. Consider your risk. So if you are a healthcare worker, you're working with a population and that patient has been tested for HIV and they're negative, that risk of contracting HIV is not there because they're negative. But if you are working with a homeless patient that's an IV drug abuser that is HIV positive, that's going to be a risk factor, especially if you have an exposure. You can test the source. So if you have a patient that you accidentally poked yourself with or somehow that happened, you're going to test that source and see where they're at. The patient can refuse, but it's something that we can do. Treatment needs to begin within hours of that exposure. And we treat those people with that pre-ep for 28 days. And then they will do like a post-exposure testing. So you will get your ELISA, your Western blot, and make sure that you don't convert to anything positive. So who's going to be involved in the care of your HIV patient? So most of the time, once your patients are diagnosed with HIV, they're going to see an infectious disease doctor. They have a lot of respiratory issues, so they're going to be seeing respiratory services, so some kind of type of pulmonologist. They're going to see a dietitian because a lot of times they lose a lot of weight because their bodies aren't able to utilize their food like they need to. Rehabilitation services. Keep what muscle mass they have. Support groups. Home health care services, because these people aren't going to be treated in the hospital. That maybe their initial treatment will be in the hospital, But they need a home health nurse that's coming out, making sure they're taking their antiretroviral medications. Long-term care facilities. Many times people that have HIV, as it goes into AIDS, they get like an AIDS-related dementia. And so that dementia affects their brain, and it looks just like your other dementias. Looks like your Alzheimer's, it looks like your dementias, and it progresses to the point that they can't do their ADLs, and they can't take care of themselves. And then hospice services for the end. So there's going to be a lot of things that have to be coordinated for these people. So let's look at the complications now. So we're going to look at opportunistic infections, wasting syndrome, fluid and electrolyte imbalances, and seizures. The first two we're going to talk about in detail. The fluid and electrolyte imbalance and the seizures, those are just things that can happen with your HIV infection as it gets worse. So many times your patients with HIV, I think it has to do with medication and it has to do with the HIV infection itself. They will get chronic diarrhea. So the diarrhea, when they eat, a lot of the food is just immediately rapidly taken out of their bodies. So they don't really have time to absorb the water. They don't have time to absorb the nutrients. And so they get a lot of fluid and electrolyte imbalances. Seizures, as that HIV invades the body, sometimes it can cause an encephalopathy, which causes them to have seizures. So opportunistic infections, we're going to talk about the top one. We have bacterial infections. So certain infections that they're going to get, one is TB. They're going to be more prone to TB. They're going to be more prone to bacterial pneumonias, and they're going to be more prone to becoming septic. So those are things that we have to watch with bacterial infections. Strep, all of those kinds of things. So now there are certain malignancies or certain cancers that our patients can get with HIV. Kaposi sarcoma is our biggest one, and that is where they just get malignancy or cancer in their bones. And it's Kaposi sarcoma. It actually starts on their skin, and it looks like these big lesions on their skin, and they're kind of purplish, and you're like, what in the world is that? And then if you look at those big lesions, those same lesions are going to be in their brain, in their liver, in their lungs, and that is a type of cancer that we typically only see in our HIV patients, because the rest of us, our bodies will fight those off. And we have that ability to have Kaposi, but our body, because we have a good immune system, will fight that off. Your HIV patients can't, so they end up with that. So Kaposi sarcoma is a big one. Lymphoma, Hodgkin's lymphoma, non-Hodgkin's, carcinomas, all of those. Then we go into viral infections. That's going to be your CMV or your cytomegalic virus. Herpes, herpes zoster, that's going to be like your varicella and things like that. Fungal diseases. This is another one that they get. It gets in their lungs, and it's called pneumocystis pneumonia. I always have called it pneumocystis carni pneumonia, but I think they've kind of developed the name as pneumocystis jirovecii pneumonia. You can get candidus. So candidus can get, which is your fungal infection, which is basically kind of like your thrush. They get it in their mouth, they get it in the vaginal tract, they can get it in their rectal vault, they can get it any of those type of places, and it's just a fungal infection that has to be treated. So the pneumocystis is a fungus that gets into the lungs. Protozoal diseases, that is kind of like your toxoplasmosis, that's your pneumocystis pneumonias, that can cross over to both of those. Okay, wasting syndrome. Remember I talked a minute ago about the diarrhea? Well, this is when they lose greater than 10% of their body weight. And they have to have 30 days or more with chronic diarrhea, chronic weakness, or fever. So to be diagnosed with the wasting syndrome, they have to lose 10% of their body weight, and they have to have chronic diarrhea for 30 days or more, or they have to have fever or weakness for 30 days or more. So they have to have both of those things, two of those things, to actually get diagnosed with chronic wasting syndrome. So as far as us nurses, what are we going to do? Well, nutrition's going to be their biggest thing. So we're going to really work with them about protein intake. We're also going to work with them about total parenteral nutrition. We're going to monitor their daily weights, look at their calorie counts, give them meal supplements, mouth care is going to be big, because they're going to get lots of mouth sores. What can we do to increase their, their appetite? Give them lots of small meals. Limit their fluids during meals. We want them to get the meal intake, not really, calories that aren't going to count. So we're going to think about all that kind of stuff. So we need to get that protein into them. Okay, and that is the end of HIV.